We've got our next presenter. William Steadman is a orthopedic principal house officer at Ipswich Hospital and a PhD candidate from QUT. He's going to speak to us around the topic of the burden of joint infections and one way to address this. Will is an orthopedic registrar, currently working in the hospital at Ipswich in Queensland, and is completing his PhD. His PhD is focusing on ways to improve outcomes for treatment of prosthetic joint infection. Will.
Thanks, Jayesh, and thanks for the invitation to present today. Good evening, everyone. So today I'm going to talk to you about the burden of prosthetic joint infections and one way to address this, which sounds like a very mysterious title, but we'll get into it. So prosthetic joint infection, or PJI for short, has been a battle for the medical profession since prosthetic joints began to be implanted over 100 years ago. This is when artificial joints, like hip or knee replacement, become infected. Often this means for patients multiple major revision surgeries to remove and then replace with new implants and months of systemic antibiotics. Rates vary around the world after primary arthroplasty between about 0.85% at best to 2% in other places. And in Australia, this means that there's estimated to be almost 4,000 new PJI cases each year. And as the number of primary joints implanted increases with increasing demand in our ageing population, the number of eyes for infection also climbs, as well as the overall rate for revision for each primary joint that's replaced is also climbing currently. It's a huge burden for both our patients and our health systems. In a Queensland-based study in 2013, the direct costs of PJI treatment were estimated to be between $20,000 and $45,000, depending on the particular treatment protocol that's used. And US studies today are estimating up over $200,000 for the more complex. For patients, treatment can be long and arduous. PJI patients undergo significant psychosocial stress, which is comparable to oncological patients. And long-term functional scores, even with successful infection eradication, are worse than the general population, with worse outcomes for those requiring more reoperations. It's a significant mortality risk as well for our patients. A recent systematic review of over 19,000 patients worldwide finding a 4% one-year mortality and over 21% five-year mortality for these patients with a hip PJI. And especially after the promise of a functionally restorative operation like hip or knee replacement, it's quite disappointing. You can also feel the sinking hearts of orthopaedic surgeons everywhere faced with a picture like this. The reason why PJI is so hard to treat is the biofilm. I'm sure this audience doesn't need a lecture on it, but it's the core driver of PJI treatment resistance on arthroplasty implants. Once a biofilm is established, these bacteria are up to 10,000 times more resistant to antibiotic therapy than their planktonic counterparts. It limits penetration of antibiotic compounds and reduces immune system activation with its extracellular EPS matrix. And it's got a multi-layered structure with its more metabolically active outer layer to spread and the inner layers with reduced metabolic activity to prevent the antibiotics from acting. And then at the center, the persister cells with little to no activity that form a nidus for recurrence post-treatment. The resistance to antibiotics can be expressed as the MBEC, and this is the minimum biofilm eradication concentration. It can be orders of magnitude higher than the MIC of planktonic bacteria of the same strain. Common antibiotic-sensitive pathogens in orthopedic device-related infection may have an MBEC of over 1,000 micrograms per mil for workhorse antibiotics like vancomycin. And so the goal of getting rid of the biofilm in PJI means we get to keep the implants that are already in there. This reduces surgical complexity or potentially the need for surgery at all. And as well as improving functional outcomes for our patients, this also leads to major cost savings for our system. So, what's one way we can try and solve this problem? It's one of the dark arts of orthopedics, local antibiotics, directly placing antibiotics into the site of infection, commonly during surgery. I call it a dark art because, like most surgical things, everyone has their own way of doing things, and the evidence for varying techniques is often a bit patchy and oftentimes a bit off-label. Looking at options, they can broadly be divided into antibiotics alone, or sometimes a carrier can be used for these antibiotics to improve their effectiveness. The most researched antibiotic carriers are bone cement, or PMMA, calcium-based substances with sulfate and phosphate, and newer hydrogels. There are also newer non-antibiotic options, which I'm not really going to talk about today, like bacteriophages. So first, let's talk about a few basics of local antibiotic therapy. Choosing an antibiotic to be used locally requires taking into consideration a few things that you don't need to consider when deciding on a systemic agent. Culture results may not be available at the time of surgery, and the surgical team placing the antibiotics often don't have the opportunity to change them later. So they need to decide whether they're going to target a known organism or whether they need to work empirically. Antibiotics are toxic to bone and soft tissues in very high concentrations, but fluoroquinolones, tetracyclines, and rifampicin have all been shown to be particularly toxic to these tissues even at low levels. And finally, if you're going to use a carrier to improve the effectiveness of the antibiotic, you need to consider the interaction with that carrier when you're placing these antibiotics. Directly placing the antibiotics themselves into the surgical site as a powder or solution has mostly been studied in PJI prophylaxis during primary joint replacement, and recent meta-analyses on this topic are actually conflicting as to whether PJI risk is reduced. We do know, though, that local levels of these antibiotics are high initially, and then they rapidly decline and are estimated to be subtherapeutic by about 64 hours post-op. One strategy to improve the effectiveness of local antibiotic therapy is to regularly administer antibiotics into the affected joint. Leo Whiteside from the US pioneered his treatment protocol for hip and knee PJI, giving gentamicin or vancomycin through a Hickman catheter that was placed surgically at the time of revision arthroplasty. In his case series of 18 to 30 patients, there are quite impressive infection eradication rates for high-risk patient groups like a recurrent PJI or patients with drug-resistant organisms like an MRSA. But there are still many adverse events which are mostly related to the catheter or renal dysfunction related to antibiotic therapy, which overall in his series are about 20%. But this technique struggles mostly with high variability in the levels and an ongoing short half-life of the antibiotics that are placed. But it is effective against the biofilm, with an animal study finding a reduction in prosthesis biofilm, bone loss, and local soft tissue reaction with intra-articular antibiotics compared to systemic administration. Another strategy to overcome the issue of a short antibiotic half-life and to get more reliable antibiotic levels is to use an antibiotic carrier. An ideal carrier that we want to place surgically is one that provides prolonged antibiotic concentration above the MBEC, complete antibiotic release, versatile compatibility with a wide range of antibiotics, and is fully resorbable with a low risk of allergies and adverse effects for our patients. Bone cement, or polymethyl methacrylate, or Perspex, is often used in orthopaedics for implant to bone fixation in arthroplasty. Bone cement has a long history of use as an antibiotic carrier, first being published on in 1970 by two German authors, Buchholz and Engelbrecht. And load-bearing temporary cement spaces are standard of care still for stage revision for infection, with the added benefit on top of that of local antibiotic elution. Mixing cement with antibiotics, though, is a balance between increasing antibiotic elution and decreasing structural integrity of the cement. And it is effective, though, with the use of an antibiotic-loaded cement spacer in revision arthroplasty being associated with a 7% reduction in infection recurrence. But antibiotic release from bone cement isn't really ideal. Concentration peaks on the first day and is quite high, but these peak levels and the therapeutic time is still quite variable between studies where they published, which is based on the heterogeneous nature of the mixes and the locations that these are being used. Some only show a therapeutic time of a few days, others show a therapeutic time of out to several months. Through experience and trial and error, there are a few ways we've figured out to improve antibiotic release from bone cement. This can be improved by increasing antibiotic concentration, synergistically adding a second antibiotic into the mix, or putting other additives into the cement like phosphate or PLGA to increase the porosity of the cement and the antibiotic elution. But really, I think we're asking too much of bone cement. PMMA curing temperatures setting in theatre can generate temperatures of up to 80 to 90 degrees, which can actually degrade the contained antibiotics, which makes, for example, beta-lactams, which are highly fragile, ineffective. Some antibiotics interfere with the polymerization process of the cement, like rifampicin, and that weakens it and can't be used structurally. And systemic adverse effects still happen with bone cement and antibiotics. Acute kidney injury risk has been recognised to increase with the level of antibiotics placed in these cement spaces. And it really has an overall poor antibiotic release, with only 25 to 50% of the contained antibiotics in the cement actually being released. And finally, persistence of the carrier has been associated with the emergence of antibiotic resistance due to small colony variants, emerging with prolonged exposure to the late tail of the subtherapeutic levels. So, if cement's not great for this purpose, what can we use to overcome these problems? A resorbable carrier is attractive to patients and surgeons, as it doesn't need a planned removal surgery to come out, and can also avoid these prolonged subtherapeutic levels, as the carrier doesn't persist while achieving complete antibiotic release after the substance is gone. Calcium sulfate has been an antibiotic carrier option also for many years. Its use in PJI has been born out of osteomyelitis management, where it's used as a synthetic bone graft and antibiotics were then mixed in. It's bioabsorbable with 100% antibiotic elution over a period of several weeks, and it's been shown in vitro to successfully inhibit and eradicate biofilms. It avoids heat degradation problems like cement because of its isothermal curing process, which means it's more broadly compatible with antibiotics. But it still has several drawbacks, in particular the risk of persistent wound drainage, which scares surgeons. Unfortunately, the comparative studies assessing success rates in PGI are pretty limited to case series or case control studies in debridement procedures for PGI. The largest case control study reported a 45% failure rate, which is consistent with smaller case series. So it appears, unfortunately, relatively ineffectual as a local antibiotic carrier in these settings. But despite this, anecdotally, it seems to be increasing in prevalence and increasingly popular in clinical practice. But different mixes of calcium-based carriers do exist. One of the more popular internationally is called Cerament, which is a mixture of 40% hydroxyapatite, which is phosphate-based, and 60% calcium sulfate. It's actually commercially available with gentamicin or vancomycin pre-mixed. And when used at the second stage revision for PJI, it's associated with a 95% infection clearance rate, which is pretty impressive. Across two large case series of chronic osteomyelitis, including 71% of these involving infected fracture fixation, another big problem in orthopaedics, the Oxford group, led by Martin McNally, reported a 94% infection eradication rate at the long term in high-risk patients. Overall, this combination carrier has significant potential in prosthetic joint infection, given its promising results in osteomyelitis, but similarly to sulfate, it has to be used with caution, and it also deals with similar wound healing problems. A limitation of this calcium-based carriers overall is that their duration of release is essentially dictated by the dissolution time of the substance that's carrying them. And commonly for the calcium-based carriers, this is really only out to about 28 days. One of the newer things we have available to us are hydrogels. Hydrogels carry significant promise in the future as a fully resorbable carrier that can be tailored to a particular clinical indication. They can be manufactured out of multiple different degradable polymers with variable antibiotic release and degradation time of the gel, and they can carry a wide variety of antimicrobial substances, as the hydrogel can be mixed at room temperature, which minimizes thermal damage. They've been combined in experimental studies with a wide range of antibiotics, antifungals, antimicrobial substances like chitosan, as well as pro-osteogenic or pro-angiogenic substances, and even various sensitive bacteriophages. Animal models have found that some loaded hydrogels are able to achieve well above the MBEC for multiple common orthopaedic pathogens, well above what bone cement or the calcium-based carriers can achieve. And the forefront of hydrogel research has actually produced layered microparticles within a hydrogel to enable multi-phase drug release, in a rabbit model releasing vancomycin and ceftazidime out to 56 days at a stable therapeutic level, while also releasing lidocaine for pain relief out to 14 days. Clinical studies, though, are more limited. In the orthopaedic literature, one particular hydrogel called defensive antibacterial coating, its commercial name, or DAC for short, is the most studied and currently the only clinically available to us in Australia. It's intended as a prophylactic implant coating, changing the implant surface from hydrophobic to hydrophilic to impair bacterial adhesion, but it's also been mixed in with antibiotics to improve their antimicrobial properties. But as a prophylactic, it's completely resorbed in 72 hours, so it doesn't have the long duration. So in conclusion, the biofilm remains a significant cause of failure in PJI treatment. Local antibiotics are effective in reducing infection recurrence, however they get in there. We have significant limitations in our understanding of what we're trying to achieve, and all our current options have significant drawbacks. And while there's promising work on better ways to deliver this antibiotic therapy, there are still a number of challenges which need to be overcome before these are available clinically. And finally, a little plug for the review article we wrote on the topic. Thank you.
Thank you, Will. That was brilliant. Actually, it's definitely an area of interest, actually, and clearly a need in the community, actually, and certainly from my own sort of specialty, from intensive care perspective, we do encounter a lot of patients with prosthetic joint infection, and as you rightly indicate, actually, it's a nightmare once it sets in. So a front foot approach, actually, the way you're sort of prescribing is the way to go, and I do hope that something works actually in that respect. And got more questions for you later, but.